for being here. This is, it's such a pleasure. We asked Emily, could we start early in our discussion and talks, and it's really, what a cool thing to ask permission to do, because you have, and people who know me know I have a lot to say, but it's really because there's so many updates, and it's just mind-boggling to me what's happened in just the past 6 weeks between World Lung, AACR targets, and ESMO. And so that all happened September through October. And it's just a lot to kind of take in a setting where we're already at a really high pace of opportunity. I really want to thank Anna as well for presenting that research. It's very cool to see what a place like Living Cancer Institute can do from a basic science research perspective. And I think that it really is such a great example of the care model from bench to family. And what I'm going to talk about is after these small molecules get through all the work and the drudgery that they are doing in the lab, it takes a long time, it takes a lot of work. There are many, many failures before we find the right one. I have the pleasure of talking about the right ones, what Anna and Cody and David and all the Nuri and all of our team do is keep on looking when something does not work or does not work to what we feel is our best ability. So it's important for her and for them to see how that ultimately translates, right, and how those successes, so they can continue to be inspired to keep on looking for these drugs for us to try. So I think it's really cool. The other thing that I think is really important, what Anna's doing, is she's really focusing right now on the metabolic component. I'm not going to talk about any metabolic stuff today. We're going to talk about immunotherapy and targeted therapy, and so an area of research that has really kind of lost its path and is being kind of re-explored is that metabolic path, and I think that's really exciting. So kudos to what you're doing. So let's start with what we should know, and if you don't, you need to. I'm going to read it. I read stats so we don't miss words, so we don't mix the message. Second most common diagnosed cancer in both men and women. Lung cancer is the most common cause of cancer death. More deaths than breast, prostate, colon, rectal, and add pancreas to that. Huge impact. 80% of lung cancers are still tobacco related. We're working really hard to eliminate the stigma associated with that. But let's be very clear that the toll among people who've never smoked is substantial. Non-smoking lung cancer ranks among the top 10 causes of cancer-related death. So here's the distribution among men and women, still more dominant in the non-small cell lung cancer space, more dominant in the adenoids. Things are happening. It's been really exciting to see when the American Cancer Society releases these statistics, and we break them all down every year, and all stats lag, right? So we know we're in 2023, but we need to see how this evolves over time. And these are the trends in lung cancer mortality in both men and women going back to 1900 to 2020. So we started to see these trends change really in around 2000 and have continued to see a precipitous reduction in mortality related to lung cancer. A lot of that has to do with really an aggressive force in smoking cessation. And you can see here, again, we were giving cigarettes to people. We were giving them to our veterans and long time for us to recognize the errors in that. So when we think about how do we get to these advances, how do we get to reductions in mortality, it's about doing better. But in order to do better, you have to know what you're dealing with. I talk to patients all the time, patients, providers, caregivers. Very systematically, we have to know what it is, where it is, so then we can determine how we're going to treat it. And the what it is has to do with the path. The where it is getting the right scans. And how are we going to treat it? Well, that's right now, it's very stage dependent. It's very disease distribution dependent. So if we can hit on each one of these cylinders, then we can have a strategic plan. We can look at things and see where we're going to go next in that cancer diagnosis. So the what is it? Well, there's a lot. Lung cancer is a lot of different cancers, and within them, there are many, many subtypes. When I was working on a book chapter back in 2017, we were putting together this graph, this chart, and at the time we were only testing for EGFR and ALK because those were the only two mutations for which we had targeted therapies. And this is the exact same pie chart that I had, and now we have drugs targeting every single one of those colors. And I've done this chart for many years. Annually, I look at what targeted therapies we have approved. This is what I put together in 2019. And this is the current 2023 one. Now you'll see I still have mobocertinib on there. Mobocertinib Takeda is withdrawing from the market, but it doesn't mean that it has a demonstrated benefit. We'll talk about that. And you'll see here, which I'm not going to talk about today, encorafenib and binimetinib, is a newly FDA approved BRAF V600E combination in lung cancer. So the drugs are not new, the combination is not new, it's new in lung cancer, and that's been FDA approved relatively recently in the past few months. So the where is it? I think the most important message is brain imaging, and we're not trying to scare people when we order brain MRIs, we're trying to be thorough, and the brain is a part of the body, and so if we're just looking, as somebody's said before, notch to crotch from here to there, then we're missing something that's really important upstairs. And so it's important because lung cancer does spread to the brain. In fact, it's the most common cause of having metastasis in the brain is lung cancer, above melanoma, above renal cell, breast, colorectal cancer. So when we think about how we're going to treat it, we need to think about what our distribution is. And stage 1 lung cancer, and this is just in the simplest terms, it's going to be isolated to a single mass. And then, as that cancer spreads down the highway and exits at the various stops, we can have lymph nodes that are just adjacent to the lung. Those are the hilar lymph nodes a little bit further down. You've got to take the highway a little bit farther, exit off in the mediastinal lymph nodes, and then spread to more distant sites, which is stage 4. And so getting into where we have really evolved, I'm going to start, they typically start in the metastatic setting and then move back, but we're just going straight into one of the most pivotal trials that have happened in the non-metastatic setting, which is the Pacific study, and which in lung cancer that cannot be resected but has not metastasized, we have used chemotherapy and radiation. We used to give it in sequence, like boxcars, and then we decided we'd put them together. And then we decided we'd put immunotherapy on the end. And that was the first time we brought immunotherapy in a non-metastatic setting. And it was tremendously successful. And now we have 5-year data that clearly states, using the drugs that you've demonstrated to be successful, give them in earlier stages. And so Pacific has done that. And so what we did at Levine Cancer Institute, has been years since this trial is in design and development and initiation, but we recognized that even in Pacific, you're failures, like what do we mean by failure? We don't mean that about the person, we're talking about our treatment. It's not a personal thing, it's what can we do better. That a lot of those situations in which the cancer progressed was locally. So meaning still within the site of that original cancer. So what can we do better at a local level? And so we started using stereotactic radiosurgery at the primary tumor, followed by the chemoradiation to the lymph nodes, followed by the immunotherapy. And this was led by Josh Heinzerling, one of our radiation oncologists. And we did this just at Levine Cancer Institute and looking at the progression-free survival at a year and many, many endpoints, all of which is coming to fruition. And so he presented this not too long ago, within the past few months at Astro. And so this is the first time our data has been released. But we had 1 year follow-up at almost 63%. And that was, in our conclusions exceeded the benefit we were already seeing with Pacific, which already was such a gangbuster, awesome advancement in the way that we treat this cancer. So that was really important. We knew this data was going to be a game changer, and NRG saw that as well. So this is now becoming a national study led by Josh Heinzerling here, Chuck DeSimone. I'm the medical lead nationally for this study, and we are randomizing what we did here versus what would be considered standard of care. And this is open in many, many sites around this country. So that's where we already were. We were kind of moving from the stage 4 to the advanced stage 3, but like I mentioned, we want to get better and better, earlier and earlier, so that we improve cure. And in tumors that are resected, there are certain situations in which we feel like the risk of recurrence is high, and we want to reduce the risk of recurrence and help somebody live longer. And so we know from many, many studies, which I've listed here, that are all older, every single one of them demonstrated in stage 2 and stage 3 lung cancer that was resected by adding platinum, cisplatin-based doublet chemotherapy, so 2 drugs of chemotherapy for 4 doses. We can improve 5-year overall survival by 5%. And really that was and has been as much as we could do. And we all agree that 5% should be higher, and we want to make that better. But up until recently, we really didn't have the capacity or the agent or the mechanism to do that. I mean, there are many, many studies that looked, how can we make that better? And really what we needed was a different drug, and hence the advent of immunotherapy in the resected kind of situation. And so right now we've got 2 FDA-approved therapies for adjuvant. Adjuvant means after, so surgery. Both of these are surgery, chemotherapy, immunotherapy. This one was the first one with approval in Power 010, which utilizes atezolizumab as the immunotherapy after chemotherapy. And so what I really want to point out here is not getting into the nitty-gritty of a lot of statistics here, but just how do we look at these graphs for people that don't always look at these graphs? And we have a good teaching opportunity. So lines that separate are important because that shows that we're making a difference. The wider the space, the more impact we have. And the longer they stay apart, the longer that benefit is demonstrated. And so what you can see here is you can see that there's an early separation in these curves. It's big, and it keeps on going even as we get out farther. So we know that the intervention that we made is sustainable, it's durable, it's real. And so that's what has been shown here. Now this study is really for the stage 2 to 3A non-small cell lung cancers resected, have received chemotherapy, and have PD-L1 expression. So need to have that immune expression. But what you can see here is, and now we have, and this was a lot of these, get updated over time versus like when you first look at the data and then later. But looking at survival, not just how long was their disease-free survival, but how long you're really living in these high tumor immune expression, we're really getting a significant 5-year overall survival of about 85%. Like that's so cool. So it really is. I mean, this is where we make our game-changing situations. And what you're looking at here is, like, this is a lot more than 5% improvement. So now we're getting somewhere. And so a similar kind of thought process here with pembrolizumab, slightly different design, a little bit more broader population, in the sense that endpoints were slightly different. We had also didn't fully exclude the EGFR and ALK space, didn't necessarily require that patients receive chemotherapy. And also PD-L1 expression was across the board, so not just in the positive 1% or greater. So when we look here, really excellent outcomes. We're still seeing, and I don't have any graphs up here, but similar. I mean, there wasn't anything really different. I'm not going to go into the weeds on the differences between these, but it just validates, again, immunotherapy after resection is very important if we want to improve our survival. The FDA approvals are different between atezolizumab and pembrolizumab, and I think what's important to note that although a third of patients did not receive chemotherapy in that arm, it doesn't mean that that's the right treatment plan. The approval is that they receive it after a platinum-based chemotherapy, and we know based on exploratory analyses that those who did not receive chemotherapy and skipped right on to immunotherapy did not have the same survival advantage. So it does not, just because the study, was a little bit broader in that, it doesn't mean it was it was the right decision. And what we've learned from that is that we really should still be giving chemotherapy based on this study. So that's really, in the adjuvant setting for immunotherapy, but what about cancers that have driver mutations? And Anna mentioned osimertinib and looking at overcoming resistance to that third generation EGFR tyrosine kinase inhibitor, which we use as a first-line treatment in metastatic lung cancer. Again, how can we use a great drug earlier? And in this situation, we should. So for tumors that have been cut out, whether or not they receive chemotherapy, if there is an EGFR mutation in them, then they should receive osimertinib. And this is, when this was presented a few years ago from a disease-free survival perspective and then an overall survival perspective, this is the kind of stuff that when you're in the room, you gasp. And I'm going to teach you some more statistics as a non-statistical person. So again, you've got this huge, separation here. And you're seeing that disease-free probability, the probability that there's no disease at 24 months or 2 years is 90% compared to 55. That's really impactful. And what was for us so impressive was this hazard ratio. We want to see these below. This is basically saying that you're reducing the risk of progression or death related to this by 73%, which is a big number. So the lower the hazard ratio, the higher the impact. And then this, in this parentheses, is your confidence interval, and that tells you, okay, what's the variability within this population? That tells me, okay, where's that on this spectrum? How many people are going to be above and below, and like, how do I think about that? This is, so the tighter those numbers are, the more impactful that is. And so the fact that this hazard ratio is 0.27, and then you have this confidence interval going from 0.21 to 0.34, it's really, really small. And you lose that impact as that number goes up and crosses 1. So here's that one, here's that line for 1 here. If we saw these things cross over here, there'd be less impact. And you can see it didn't matter how old you were, like, whether you were Asian, non-Asian, what stage your disease was, which EGFR mutation you had, did you get chemo, all this kind of stuff. Everything shifted towards, you need to give osimertinib. And this was a game changer. We knew it was a game changer when it was presented. And then just this past year at ASCO annual meeting, we got the survival data. And so this is where, you see those numbers that I just showed you, and you say, okay, we think this is big, but do you live longer? Is more treatment going to help you live longer? Or is it just going to keep the cancer away? Well, when we saw those initial studies, keeping the cancer away is a big deal, especially if we're talking about brain metastases, if we're talking about cancer that can become symptomatic, especially if we're talking about a medicine that is in general well tolerated. But again, we did not know until presented at ASCO annual meeting this year whether people were living longer. And we do now know that people live longer when we give osimertinib in that situation. That's just one of the targets I showed you. We've got 10 targets in the metastatic setting that we have drugs for. And this is just EGFR. Well, just the other week, we got the ALK data. So this does not yet have an FDA approval, but we are super pumped to have this data out there, presented just on October 21st at ESMO. And it's basically using alectinib in an ALK rearranged resected tumor, and this was for 2 years that they take alectinib, whereas the osimertinib is for 3 years. And so this is the first data we've seen, disease-free survival. And the curves are very similar to what we're getting out of osimertinib. If you look at a totally different disease, conceptually hitting on the same idea of design and opportunity to reduce the risk of having cancer progression and ultimately improve survival. So early data, both in the osimertinib setting and in the alectinib setting for EGFR and ALK diseases respectively. These drugs penetrate the blood-brain barrier. We're looking at how can we prevent spread to the brain, how can we protect the brain, and we're getting that. So if we're doing it after surgery, why not do it before surgery? So what can we do even earlier? And is that going to make an impact? I'll tell you, when we've looked at chemotherapy in the adjuvant setting, like I said, 5% approval and 5-year overall survival. There are data in using neoadjuvant means before surgery with chemotherapy, and it's essentially you get the same. You get 5% approval and 5-year overall survival. But there's this whole concept of, again, we need to bring the immunotherapy in. And are we going to get better outcomes if we give immunotherapy before we cut the tumor out? Like, do we do something with that environment? Are we, harnessing the immune system differently if the target, meaning the tumor, is actually present versus already cut out? Which is a different concept than what we think about with chemotherapy, which is there to kill the cell, the micrometastatic cell that could be left behind. And so conceptually, again, bringing this in before surgery. And so this is Checkmate 816. This is the first study, first approval that led to bringing in chemotherapy and immunotherapy in the neoadjuvant setting. And the difference here too is that we're giving them together, not in sequence. Is there any advantage there? So this looked at platinum-based doublet with nivolumab for just 3 cycles, and that's fine. Like, we have data that says, you probably only need to give 3 cycles of cisplatin if you dose it correctly. And so This was a very appropriate design, doing 3 cycles. And so you're able to probably minimize some of that systemic treatment. Currently, we give 4 cycles of a platinum-based doublet after surgery, followed by a year of immunotherapy. And this just said, do 3, put it together, go to surgery, and be done with it. And so we've got median event-free survival here, 12 months, 24 months. The 3-year updates were presented at a European Lung Conference in March of this year. And so we're still seeing those curves separate. You know, they're staying out the 3-year data, which I don't have here. And that's really important. What we're learning is what we get out of doing the treatment before surgery is we actually get to see the response, right? We get to know, was that sensitive to the treatment we gave or not sensitive? And so pathologic complete response means that truly there's no cancer left. And so you can see that with the addition of nivolumab, that's a substantial change in that pathologic complete response. So, you know, if you follow the conversation, given it before, but should we give a little bit after also? Should we give it a bookend on the backside? I've just told you that 2 of our adjuvant approvals do immunotherapy for 1 year. Told you the neoadjuvant approach with 816 is 3 doses. So, do we need to still get a full year? Well, let's be very clear, nobody knows, okay? So we don't know how much immunotherapy people should get. We've got the information on the trials that have led to the FDA approval, and we follow the data and we follow the science, but we really don't know. And so we're doing a lot right now to try and understand what is the correct length of time, and that's through a lot of blood-based analysis and looking at what we call ctDNA and things like that. So, but Keynote 671, this is our first perioperative approval, and this essentially happened the other day, also at ESMO, kind of pre-ESMO, kind of came out little unexpectedly, kind of broke an embargo, but FDA did, not Merck. And so Keynote 671. So what this does is pembrolizumab is given with chemotherapy for 4 cycles before surgery, and then the pembrolizumab is continued afterwards to finish up that 1 year. And so what was a little bit interesting here is that this trial design has dual primary endpoints, which means you have to meet a lot of statistics because you got to get both of them right. If you only have one of them right, you don't meet your endpoint. And so they had to meet both of these, and they not only showed event-free survival, but also overall survival advantage. And so this is really showing us that doing this is going to help people live longer, and it's going to help people live longer than just giving chemotherapy. And so that led to that approval a few weeks ago. And again, you see these pathologic complete responses, and then there's another path term called major pathologic response. Across the board, really, we're seeing very similar findings. Checkmate 77T. So this was also presented at ESMO a few weeks ago, but this is the utilization of nivolumab, now different than 816, on both sides of surgery, so pre and post, and doing the chemotherapy for every 3 weeks for 4 cycles, followed by surgery, followed by nivolumab to complete 1 year. So similar to the pembrolizumab design. And again, we're seeing event-free survival here, the 12-month event-free survival. You're seeing these increases across the board with all these studies getting into the 15-18%. You're getting these significant improvements in major pathologic responses. Survival is not mature for Checkmate 77T. And then here we have a similar study with a GN. This is using durvalumab, another immunotherapy with the 4 cycles of chemotherapy and durvalumab in the neoadjuvant setting, going on to surgery and then having durvalumab. So across the board, we now have 3 studies all published or presented, within hours of each other, days, 3 weeks ago, using 3 different immunotherapies with chemotherapy and immunotherapy surgery, and then immunotherapy afterwards. And all of them have very, very similar outcomes. Again, just supporting the opportunity. So when do you use this, and when do you use adjuvant? And when do you use Pacific? Because I started with Pacific, which is your cancer that's more advanced, that you can't cut out, that you're going to give chemotherapy and radiation to, followed by immunotherapy. And then we talked about 2 studies where you cut it out and then you give chemotherapy and then you give immunotherapy. And I've talked now about 4 studies. 1 where you just give chemoimmunotherapy up front for 3 cycles and then have surgery and nothing afterwards. And then 3 studies where you give immunotherapy and 4 cycles of chemotherapy, and then up to a year of immunotherapy after that. And then your mind is going to explode. And this is what I do. Like, this is what I do. But I think what's really important is we're seeing opportunity, and these are not the same populations. So one of the things that these neoadjuvant approaches are providing for us is a surgical opportunity for a more advanced cancer that otherwise may not have been able to be cut out. So the difference there is we're operating on more advanced cancers in these studies, which is not something that we've entertained previously based on lymph node distribution. And when Pacific came out and we were adding immunotherapy, and we have these 5-year overall survivals that we haven't gotten, yet out of surgery, we're very excited when there's more advanced lymph nodes. Remember, we talked about the cancer traveling from the hilum to the mediastinum. That's more advanced, higher risk for coming back, and also higher risk to cut out, right? We got a heart, we've got a swallowing tube, we've got all these things right here, and some of these lymph nodes we can't get to. But what these neoadjuvant studies are doing is they're giving us an opportunity to do surgery where maybe we were less comfortable. And we're seeing that people are living longer. So we're winning. So when we think about how we're making that impact in the earlier stages, I gotta go back to what's happening in the metastatic setting. We've got 2 things that we can do if we want to improve what we're already doing in the metastatic setting. Either improve the first-line treatment or you improve the second-line treatment. And so both of those things are happening. If we only start thinking about one, we miss the other. And so we've got to be doing both. So I'm going to spend the last part of my discussion on the influx of where we're going. And I'm certainly not going to be able to cover it all. What I am not doing in this talk is talking about the new BRAF data. I'm not talking about the new KRAS data. Really kind of sticking with studies that have recently been presented that I think actually will have impact today, tomorrow, really live impact. Because these are what I'm going to talk about are situations where we're improving what we were already doing. So I'll just mention FLAURA2. FLAURA2, our first standard of care right now in the first-line setting of a patient that has an EGFR, exon 19 deletion, LA58R mutation, lung cancer, so metastatic, is osimertinib. So that's our current best drug. We know, even as Anna mentioned, that these drugs work well and they work for a period of time, but we hate cancer, and cancer also hates to be controlled. And so there is a mechanism that it starts to grow again. We want to understand why, so that we update our second-line treatments, but we also want to improve our first-line treatments. So there's this whole concept of adding chemo to our targeted therapies, because can we kill cells? Can we reduce the volume of cells in the body? And does that improve outcome? This has been tried many, many times before. with other EGFR tyrosine kinase inhibitors, and it has not demonstrated a benefit. Osimertinib is a little bit of a different drug, so we've been waiting to see kind of what this was going to look like. And we do see that it improves the progression-free survival. What we don't yet know is really how does that translate to survival. Again, if we're adding something, osimertinib is a pill. If we're adding an IV treatment, that changes some quality of life. We're adding toxicity. Are you really going to live longer by adding more? Even if we're deferring the time that cancer progresses. But there was an improvement by over 9 months by just adding chemotherapy to the osimertinib. There actually was an improvement even in the control of the CNS disease, so central nervous system, so talking about brain. And I think this will be really, really interesting. I mean, I will say I integrate chemotherapy into my EGFR-based treatments, and I think it's very exciting to see where this is going. This is, again, at first line, so starting with both. And I think what we'll see with this is, how do we determine people that would serve best by adding more? This may not be the right combination for everyone, but it certainly does provide an opportunity. And so still thinking about the first line, is there anything different from using osimertinib? There's another drug out there that's FDA approved for EGFR exon 20 insertion, amivantamab, and it's a really interesting drug that's a bispecific antibody. It targets EGFR and MET. And so one of the reasons that cancer grows on osimertinib is that a cancer will start growing MET. I'm just simplifying this as much as possible, but if we hit both of them up front, are we avoiding that mechanism of resistance? And so this is Mariposa. We've been following kind of these studies for years, and so it was really nice to see these come out recently. Lazertinib is similar to osimertinib. It's a third generation EGFR tyrosine kinase inhibitor. It is not FDA approved. So this was amivantamab plus lazertinib versus osimertinib. And the response rates were similar between the both. We were getting a little bit longer, like 9-month duration of response longer with the ami-lazertinib arm. We don't have the survival data yet, and we definitely are bringing in more toxicity with amivantamab. It's got a very specific side effect profile. And so I'm using this as a fantastic example of how we need to, think about this. At the very beginning of me getting up here, I talked about strategic planning, and that's really what this is all about. What is our long-term plan in the management of the cancer? Right now, this is a lot of what our standard of care is. We start with osimertinib, we may go to chemo, and what we saw at ESMO was, or what we, this was pre-ESMO, the FLAR2, but as I just showed you, osimertinib plus chemotherapy is getting that a little bit longer, but then what are we going to tag onto the end? And then this Mariposa, if you bring in amivantamab plus lazertinib on the front end, then how are you thinking about your drugs and using them in the right space so that you're getting the longest benefit, and then you're looking at your toxicities. And so it's going to be, there's a lot of decisions that need to be made. So what are we going to do after if we didn't do an amivantamab based regimen on the front end, and we've been using osimertinib as the front end? This is Mariposa 2 and uses amivantamab plus chemo plus or minus lazertinib after progression on osimertinib. And this is a really important space, one where we've been kind of waiting to see where this is going. And so what you're going to see here is that doing amivantamab plus chemo plus or minus lazertinib is definitely giving benefit over just doing chemotherapy. And it doesn't really matter whether you've got the lazertinib there or not. There's not that much of a difference here, but you're definitely adding toxicity with the addition of lazertinib. So we'll see where this goes. We don't have this FDA approval yet, but this is very exciting data, and it's independent of the tumor MET expression. I mentioned that this drug targets both EGFR and MET. The data right here is not specific for progression on osimertinib if there's MET. It's just progression on osimertinib. So this is, I think this is really important too. And again, I think what I'm getting at here is like, wow, we've got options, and that is so cool. How do we use these? One of the things that we know is that most of our tumors that have mutations are not sensitive to immunotherapy, and we've seen response rates at 0 to immunotherapy. And a lot of what Anna and Cody are trying to do is, how can we take an EGFR resistant tumor and turn it from cold to hot, right? Make it sensitive to immunotherapy with some of the stuff that they're designing right now. But time and time again, we've seen these studies and that just say immunotherapy is not going to work. There was some signal in another study that was done that used carboplatin, paclitaxel, atezolizumab, and bevacizumab that showed, well, maybe that combination gave some benefit to these patients with immunotherapy. But it was a small subset. This was designed to look at that. It was done in South Korea, not in the United States, but it had almost 230 patients, 215 of them had EGFR mutations within the tumor, and almost half of them had brain metastases. And we could see here that the benefit truly was in the arm that had immunotherapy, bevacizumab, paclitaxel, and carboplatin over chemotherapy. And so there's, what was driving this? You'll see another drug up there that I haven't mentioned today, bevacizumab, which is a vascular endothelial growth factor antibody, so working against blood vessels, and we know this already works in lung cancer. But maybe that drug is what's enhancing that environment to make that tumor more sensitive to the immunotherapy. So it may not be just that the Bev is added, but it's the Bev in combination with the immunotherapy. So bringing another potential treatment after someone has been treated. So this is, going back to ALK. So, it's walking away from the EGFR space and getting into the ALK space. For people that are kind of watching drugs that are in development, this is one. This is a new valent drug, NVL-655, and Jessica Lynn presented this at AACR Targets. And this is a drug that's showing a lot of promise. So you see this chart in a lot of different places, really important. ALK is not just ALK. ALK is all of this. And tumors can have one, tumors can have two, tumors can have this plus another. And so it's not just about knowing the ALK rearrangement, but which one is it? Because in this stop sign chart here, you can see that there are some mutations that are resistant to certain drugs. And so we talk about G1202R often about being a resistant mutation. We talk about I-1171 as being this one right here, 1171N, about being a resistant mutation. And as we think about our first, second, and third generation ALK inhibitors, we want to improve upon that as tumors become more and more resistant. How do we find new agents that are going to help us with that? And it was very exciting to see finally, because there's been a lot of buzz about this drug, but to see that it's demonstrating responses even in people that have been on 3 ALK inhibitors and chemotherapy. So, I think it's really just a point in concept of like, there are options, right? And staying healthy and walking and eating if you have cancer is important, because there is a future treatment that may become available. So ROS1 is another mutation in lung cancer that has targeted therapies. Nuvalent is also developing a ROS1 inhibitor that's very promising as well. This is one that was recently presented at ESMO that was demonstrating, you can see these very high response rates, 92% in the first line setting. So very, very high responses. Not all things that we do work. The FDA has worked hard to help us get access to drugs faster that are promising, but part of that is that we have to ensure that they continue to be promising, and if they are not demonstrating that, then we need to rethink that access. And so this is one of those situations. Mobocertinib has been around for a long time. We've looked at it in the EGFR sensitizing space. It was kind of set aside as other drugs were coming forward, and then it was kind of brought back because it was targeting exon 20 insertion, which is a resistant mutation and has limited drugs available for it, and it was working. And so it received accelerated approval in this space. And for some people, it's been an effective drug. When larger studies have been done, the drug did not demonstrate that the same benefit that it previously demonstrated, and so it was withdrawn from the market. What that means is that anybody who's on this drug that's demonstrating benefit continues on the drug. We don't take it away. The company doesn't take it away. The FDA doesn't tell you have to come off of it. It just means we don't think it's the best drug. We don't want to put somebody on it new. And so there is another drug, amivantamab, which we've talked quite a bit about, has its first FDA approval in the exon 20 insertion space. These are very different drugs, okay? Mobocertinib was an oral targeted therapy. Amivantamab is an intravenous, like I mentioned, a bispecific antibody. Side effect profiles were different. It was kind of nice to have an option to think about it. But mobocertinib should no longer be prescribed, and amivantamab is currently our only drug in the space. The good thing is despite the complex side effect considerations with amivantamab, there's some different formulations that are moving forward and make that a much easier tolerated drug. Just to fully disclose, amivantamab has a risk of infusion reaction. So, it's manageable. It's something that we monitor for, we predict for, we prevent, that sort of thing. But we really are focused on ensuring safety and tolerability. I'd be remiss not to mention small cell, a really complex cancer that does thus far not have targets, does not have kind of a biomarker-driven treatment paradigm. We're getting there. We're trying very hard, but really have been limited in our ability to do that. So this was exciting to see also at ESMO, this bispecific engager of the immune cells targeting DLL3. And I think what's really important here is that this is a study with a cancer that grows quickly, spreads quickly, and has a very short survival. And these patients, the 220 patients who were enrolled in this trial, had received at least 2 prior therapies and had response rates as high as 60% and survival of over a year. And that is a very important step for small cell. This is very promising, and we'll be very excited to see this drug, this family of drugs move forward. So that's what we do when we already have cancer, whether it's advanced, metastatic, but we recognize that, as we've already talked about, the #1 cause of cancer-related death, and so how do we improve on that outside of our treatments? Well, we diagnose it earlier, and we find the cancer. And so this is where we come with lung cancer screening. This is not new. Lung cancer screening actually has been around for a decade, a decade, and yet less than 6% of eligible patients are getting screened. By screening, we're able to achieve a 20% relative reduction in the risk of death from lung cancer. Mammograms are about 40%, and lung cancer screening 20%, which is very important. The screening guidelines changed the other week. Like literally everything changed. So updates abound. And where this has gone is that the initial guidelines were ages 55 to 74, 30-pack year tobacco history, and you either needed to still be smoking or you quit within the past 15 years. And that's what led to that statistical analysis and the reason for having a low-dose CT scan once a year. 2020, the Nelson study showed that we were getting even greater reduction in lung cancer mortality by expanding that into our youth and even lighter tobacco histories. And so the guidelines changed in about 2020 that went from 55 to 50. And they really didn't put like a back end on that. They kind of took it up to 80. That's a little less enforced. And then the smoking history of 20-pack years, but you still need to be active or quit. But what changed the other day was they eliminated whether you've quit or not and when you quit. So we want everybody to quit, and we want everybody to be a long-term non-smoker. However, the risk does not go away even with smoking cessation. And so we cannot exclude people that are 16 years out of their quit and then not celebrate that success and then not continue to screen. So that's what changed. There's no longer a requirement for how many years has it been since you quit. So with that change, 5 million more individuals are eligible. And so really imperative to screen, because that's ultimately one of the things that's changing survival. So if we think about those mortality curves that I showed at the beginning, here's our survival curves. And so it's not just about the treatment. We're seeing these curves are changing, not because of just stopping smoking, because I already told you non-smoking related lung cancer death is in the top 10 of cancer-related deaths. It's about having better treatments, whether it's targeted therapies, figuring that out, figuring out the immune checkpoint system, improving our staging, and getting good brain MRIs, having better surgeries, whether it's video-assisted, robotic, and then screening people so we're finding those cancers earlier so we can improve that survival. It's a really impressive thing to witness, and you can see that this really just has happened, seeing these survival curves. So truly with all of this, we may move out of that #1 spot, right? This is when we're not talking about the ACMs last night and being #1. We don't want to be #1. We want to pull out of that. So I'll stop there. Thank you. I know it was a ton.